Welcome to the new EIU podcast. How can we optimize decision making for complex and high-risk kidney stone patients? Today we are joined by Professor Bhaskar Somani, Dr. Matthew Breeggemann, and Dr. Timothy Bryant. Together, they will discuss the role of multidisciplinary teams in managing complex stone cases. The conversation centers on how input from urologists, nephrologists, and radiologists can support more effective and personalized care for complex or high-risk patients. Join us as we embark on this informative journey.
Thank you very much to EIU, to the EIU Education Online, for giving us this opportunity to record this podcast. First of all, I'd like to thank our listeners, to EIU, and to the podcast team. I am Professor Bhaskar Somani. I'm based in Southampton. And with me, I've got Dr. Matthew Breeggemann, nephrologist based at Kidney Stone Prevention Center at UCSF, USA, and Dr. Tim Bryant, interventional radiology consultant based in Southampton, UK. Thank you very much, Matthew and Tim.
Sure, thanks. And thanks for having me. I'm Matthew Breeggemann. I'm an adult nephrologist at the University of California in San Francisco. I'm the medical director of the Kidney Stone Prevention Clinic here and also the medical director for the Oxalosis and Hyperoxaluria Foundation Care Center Network.
I'm Tim Bryant. I'm working in Southampton with Bhaskar, and I've been part of the Stone Service for the past 16 years, member of the MDT. I'm an interventional radiologist as well as diagnostic radiologist, so I have a role in both treating the stones and diagnosing the stones. And thank you to EAU and Bhaskar for the invite to talk today.
Thank you very much. So I think our listeners would be familiar with the episode 1, which we recorded previously, which was about identifying high-risk stone formers and how we can improve early diagnosis and referral. And that is available from the EAU website and the other usual podcast channels. And of course, this is based on the Smart Stone MDT consensus paper that was published in World Journal of Urology. So the focus of today is to see how we can optimize decision-making for complex high-risk stone patients. And really, the idea is to check if clinical decision-making within stone MDT is complex and to highlight both the human and systemic factors that can challenge the collaborative decision-making. So I would start with you, Matthew. What do you think are the potential challenges of reaching consensus when making clinical decisions within the MDT? So, for example, how do patient preferences like CKD, chronic kidney disease, metabolic concerns influence MDT decisions from your side?
Yeah, I think for me is probably time is one of the main barriers. I would say, we have a limited amount of time, of course, to see our patients. And so talking about all of the tests that you're, hoping the patient completes, like imaging, the 24-hour urine collection, maybe genetic testing, just takes a lot of time to get through those. And as you brought up, a lot of stone patients may even have chronic kidney disease too. Maybe that's the priority that they're hoping to address for that, particular visit, which is a whole different type of discussion, really. So, time is, I think, a major barrier.
So multiple factors, but time seems to be an important element, which sometimes is missing. And Tim, from your side, what are the imaging limitations or variability interpretation after MDT agreement?
I think modern technology has ironed out quite a lot of the sort of variations in imaging. So on the whole, you see a balance across sort of all units, really. I think there is an element of experience. So I think it's important that the people involved in MDTs have experience in diagnosis of stone disease, treatment of stone disease. And that then gives the MDT an opportunity to provide a second opinion, to reinterpret images if necessary, and to help planning. I think time is always an issue, as Matthew says. But I think, on the whole, variability is reduced. And I think we do get some good quality imaging, and I think that's vital.
I think so. The quality of imaging and the type of discussion, the depth of discussion is important. I completely agree. Matthew, how do patient preferences, do you think, influence these MDT decision making? And do we really should take that on board more often?
Yeah, I think for me, just kind of comparing to maybe a general eval that I might have for somebody with CKD, where the discussion may be more centered around monitoring labs, for instance. For a stone patient, it's talking about all these tests that you want, imaging and 24-hour urine, which was, really cumbersome, but so valuable to their care. So for me, if I don't feel like I have the patient buy-in for the tests I want them to have, I should expect, no tests to be back at the next visit, or maybe they just don't show up at all. So I do spend a lot of time talking about why I feel the test is valuable and how it might help them, especially if this is sort of their first run around with something like a 24-hour urine collection.
That's great. So I think the compliance can be a problem, but you can influence that, right? I mean, as clinicians, we can all influence compliance to some extent. I agree. Tim, from radiologist side, are there any limitations in data collection and imaging that sometimes make consensus hard to reach? Because, the interpretation can be different and the clinical, radiological, are there any differences to come to a consensus, which is sometimes harder?
I mean, I think from MDTs in general, one of the biggest issues is the lack of clinical information, because a lot of imaging is tied in with clinical information. It's tied in with the previous investigations, biochemical analysis, if that's available. So there are lots of aspects to radiology which don't necessarily just come down to imaging. And I think one of the important aspects is to have all that information on the table. So when you discuss a patient in MDT, it's important to have everything there, everything available. And that can affect then how you interpret the imaging. It can affect how you discuss cases and sort of arrange intervention or whatever other treatment options. And the other problem, I guess, is time. So in terms of data collection, in terms of research, all of those things come with time. That's outside the MDT setup, but it's important that that's sort of thought about as well.
Yeah. And Tim, do you think there are some difficulties in hierarchy, let's say, when it comes to the final decision making?
I mean,
not usually.
Not in my experience. I think each person that attends the MDT comes with their own sort of area of expertise, and I think the decision making is in general it's the basis of everyone's opinions where relevant. So I would maybe talk about the anatomy. I would talk about potential approaches from my perspective. You might talk about other aspects, but I don't think I never see that there's a particular issue with hierarchy, certainly not in the way we run things.
Yeah, no, I agree. Matthew, just to say, do you think having a designated facilitator or chair in these MDT situations can really help streamline shared decision making?
I think for me, and I guess that kind of feeds off the hierarchy, I kind of like I think the Stone MDTs are really amazing because you have different members of the team that have their own skill set, which by no means am I a urologist, and our urologists by no means are nephrologists, and neither of us dietitians. And so we come with our own skill set and we build on that over time as we treat more and more patients. And so I think there's just a lot of inherent respect for all of the different specialties and people involved. And so I think for me, probably no chair would make the most sense, just so kind of maybe eliminating the potential hierarchy thing that we talked about.
Yeah. So maybe you need somebody to navigate, but it might be whoever knows the patients best. It doesn't have to be a designated person, right? I mean, I agree. Yeah. I mean, just to check on some things about decision making. Now, I'm going to give you a hypothetical scenario to both of you, and I want you to share both from a nephrology and a radiology side of things, what you would see or think about that scenario. So when it comes to decision making, obviously you have decision makers, but let's say there was a young lady, let's say a 38-year-old lady with medullary sponge kidney, with recurrent bilateral stones, nephrocalcinosis, and now she's got a new stone of, let's say, 1.5 centimeter in the lower pole, and the renal function is declining slightly, and she wishes to avoid surgery. Now, Matthew, if I can ask you first, what should the MDT prioritize here? Intervention, medical optimization, or how should we go about, managing this lady?
Yeah, I think it's certainly a challenging situation with somebody with a really large stone to start with, and of course with medullary sponge kidney, persistent risk factors for new stones and existing stone growth. So I would like in that particular case to really hear from the patient and what's the his or her thoughts about why they do not want surgery. And to really explore that. And of course, maybe they have some specific surgical logistical questions that I would have to get help with from our urologist, of course, to explore that. But I would say anything and everything to treat that patient. Not only maybe she never wants surgery, that's fine, but we should still do our best to try to prevent that stone from getting bigger and then new ones from forming. So that's, I think, where a lot of nephrologists would fall in that type of case.
And Tim, just to check from a radiology point of view, in such a complex case, what are the challenges, radiological challenges that would help in the decision making, or that would galvanize that process of decision making?
I guess it's a wider question, isn't it? In terms of, you've got a patient who's recurrent stone form, where we should have some previous information. We should understand the optimal medical approach. From a radiological perspective, you look at size, location, speed of growth, how easy or difficult it will be to get into. You'd want to know, is the renal function declining because of the stone, because of where it is? Is it declining because she's had multiple surgeries in the past and actually that's feeding into the sort of the renal function? And then depending on all those things, depending on her opinion, is early intervention going to be less morbid than waiting and seeing if it grows further if there are no medical options? So you do have to take patient wishes into account, obviously, but I think there are a lot of other things to consider, some of them radiological, a lot of them sort of medical or surgical as well.
Yeah. And I guess, as both of you said, it's important to speak to the patient and find out why and explore that further. Because otherwise, this patient is a difficult one. She's young and she's got a difficult disease. Yeah. Matthew, if I can ask, for you, what does effective MDT decision making looks like in practice, in reality, really?
Yeah, I think, we talked about this earlier too. The first and foremost, just involving the patient and seeing what are their preferences and how do they want to approach the treatment plan that you think is best for them. So again, we may recommend genetic testing. Do they have some concerns with that? Is the test free or is there a cost? Do they want a CT stone scan or an ultrasound for, various reasons? And talking to them about the value of the 24-hour urine collection. So I would say first and foremost, getting their buy-in, and then obviously having the urologist and nephrologist and perhaps dietitian all on the same page too, just to promote adherence at the end of the day, because it's it's incredibly tough when you have all these tests ordered and then you see them next and none of them are done and you're sort of stuck from step one again, and just not helpful for anybody involved.
Yeah. So to complete that cycle of investigation rather than leaving it halfway or not doing it. And Tim, what role do you think radiologists play then? And I know we are actively involved and we make this decision, but in general, what role do radiologists play in guiding this decision making?
I think imaging sort of is a big aspect of managing a lot of these stone makers, isn't it? So you need to look at the risks of each type of imaging. You need to look at the risks of potential sort of radiation exposure with CT. Is ultrasound optimal? With imaging, you can identify anatomical, so particularly with CT, anatomical variations, other things that might cause stone disease. So I think you're basically, you're involved in the diagnosis. You're also involved in the follow-up and optimizing follow-up and almost protecting patients at the same time.
Thank you. So I just wanted the audience to once again to remind them really that the SmartStone MDT paper is out, and that gives in a lot more detail the roles and responsibilities of the MDT members and how decision making can be done in a safe and in a more robust way for complex patients and complex kidney stones. Matthew, if I can come back to you, from your perspective, what are the biggest benefits of shared decision making for these high-risk recurrent stone patients?
Yeah, I think just adherence for me, just having the tests that I really, really want completed and back before the next visit. So I think, making assumptions of what the patient's going to want based on your own beliefs and sending all these tests and having all this, amazing timeline and all the perfect orders but they don't, they still have a lot of questions or they have concerns or they don't maybe agree with that plan. It's just not going to work out at the end of the day for the patient.
Yeah. And Tim, similarly, if you have shared decision making and the patient is involved, as we have said, because this is important, do you think it leads to more consistent imaging pathways and maybe fewer scans?
Yes, I think probably does. If a patient, if you've got a obviously shared decision making, you've got a defined pathway of what you want to happen. Patient understands whether you're going to follow them up on a symptomatic basis, whether you're going to follow them up on a routine timeline basis. But I think it does. It helps clarify sort of that particular patient. These are complex patients. It helps clarify exactly what they need and when they need it. And if you've got an established pathway and you know exactly what you're meant to be doing, obviously it's going to help. And often these patients aren't just from your center; they might be somewhere else. So actually, it's important from a communication standpoint.
Otherwise, you end up repeating the scans and not reaching anywhere. Yeah, true. Matthew, can I just ask from your experience, do you use any clinical decision support tools or patient decision aids sometimes in some cases? And is there a role for it? If we don't, should we be using it?
Yeah, I haven't incorporated that in my practice. I have maybe this actually is an example of what you're asking, but we refer them to maybe some website. Like in the United States, we have the National Kidney Foundation, which has some nice descriptions of sort of what tests for stone care and what are kidney stones, and sign us some general information that you may not really have the time in the visit to sort of go over those things. So I haven't personally handed out pamphlets or anything to patients directly, but I try my best to explain through words. And at the end of the visits, we write pretty detailed summaries about these are the 4 tests we want done, when we want them done, and why we're getting them. So I do think that helps.
Okay, that's good. So I think from our experience, I can tell you that we also direct them to websites, and sometimes EAU websites, the European Association Urology, and they have been running the Stone MDT for almost, I would say, 15, 16 years. It's quite a formal process. And we do see that impact of Stone MDT, especially in the complex patients. And I think this is something that probably almost all urologists who treat stone patients and nephrologists and other specialties involved in stone patients should actually do. If we can move on and just to check about shared decision-making and optimization, I'll start with you, Matthew, again. I mean, what communication strategies maybe could help streamline the MDT and shared decision-making? So what are the communication tools, apart from, implying on the compliance and making sure they're compliant? What are the communication methods would you probably rely on?
Yeah, I think for me, I will give you an example of maybe some of the harder cases. So the easy ones, of course, everyone, hey, you're the doctor, I'll do, whatever you say, and I'll have it perfectly on time, and we'll meet again right on schedule and go over everything. The harder ones are maybe some patient that may challenge you a little bit, which is rightfully they have that opportunity, and they should challenge us if they feel like that's what they want. An example that might be, hey, you told me you want me to do this genetic test. How has that helped you in the past? And I might give an example of where, I have these patients with rare stone disorders that the test results completely changed my approach to help them, and completely change everyone's approach to help them. And so those are examples. And that's usually when a patient will buy in on a genetic test, for instance. That's been my strategy a couple of times.
Okay. And Tim, do you think digital tools or shared platforms improve the process? I mean, how can they improve the process even further for the MDT, especially for complex cases?
I mean, digital tools inevitably will improve communication, although, as you know, the NHS, lots of digital systems don't talk to each other. So that's the first. I think the move from the old way of having an MDT in a room with people there, which was limited to then those individuals in the room, I think has improved to a certain extent with the use of Teams, Zoom, all these other sort of platforms, in that you can get other people in, so you can get an anaesthetist in their busy schedule. You can bring in sort of consultants or team members from outside if they've got a particular interest in a case to discuss. So I think that's opened up the discussion to a wider group potentially if needed, and that's got to be good for patient sort of treatments or for patient management.
So it involves a wider community, which otherwise would be more difficult if we just sat in a room, and probably makes the time more efficient, I guess, for some of these discussions. Matthew, if I can ask you, what do you think in future, looking ahead? Is there a role for AI, or again, some kind of decision support systems to help reach a consensus maybe? Because sometimes it may not be as easy.
Yeah, I think living in the Bay Area and San Francisco, I should have more of a exposure to AI, but not for me personally yet. But I was thinking about this recently, and I think maybe you could engineer AI to screen your electronic medical records to identify high risk stone formers that maybe weren't already referred to your stone MDP, maybe they stone MDT, maybe they already have really high urine oxalate levels and they haven't been referred, and that would be somebody you'd really want to see in your clinic. Or maybe you look at your own panel with AI and everyone you treated with thiazide, and have that thiazide help those patients, and trying to use AI to your benefit. And that might help you treat, future patients, of course, that come through your stone MDT.
Tim, can I ask you, do you think stone MDT members need some kind of formal training or some kind of training for this collaborative decision making, or is this something you can learn on the job?
I mean, it's interesting. I think a lot of people have learned it on the job. I think one of the things that was introduced, it must be, again, 10, 15 years ago, was the necessity of MDT members to undergo sort of advanced communication skills training, which I think was probably of benefit, particularly in some cases. In a way, it's important as a person participating in an MDT to understand where everyone else is coming from, to understand sort of the role of stone biochemist, the role of the urologist, the role of the sort of the nurse specialists, the nephrologists. And I mean, at the moment, that's learning through participation. And you're right, maybe it would be useful to have a bit of information about that prior, but yeah, I don't think it's absolute necessity.
And Matthew, how can MDTs better incorporate patient preferences in the decision making? I know we do it sometimes, but how can we get better to have this patient, preferences?
Yeah, I think just giving options, because maybe or probably it's just true. The average patient is not going to, have done a bunch of research and, what's the best imaging test for me, and what's the best, way of learning about my urine parameters that predispose me to stones. Like, they're not going to have that. So they are depending on you. And so giving them, all the options on the table, I think that's been my approach and our approach here. That's worked really well. Like, we have this genetic test or this one's sponsored and free. This one's a bigger panel, but maybe a cost. And here's your imaging test options. And you have a variety in the United States of 24-hour urine collection companies, maybe at your own center or something that is mailed to them. This might be true. We have patients that live 6 hours away from us. So mailing at them the 24-hour urine kit is going to be much more likely for them to do that than them driving all the way up here and then doing the collection and dropping it off, which is not realistic. So just giving all the options and just seeing where they want to go with it. And then that gives them time to ask the questions about, what do we think, or what do they want to do?
Yeah, and actually, maybe this way there will be more active participation and a better buy-in from the patients,
Absolutely.
So just to recap, the Smart Stone MDT paper was published and it recommends reaching a consensus, but it's based on a case-by-case discussion, and the decisions must be documented. And the lead clinician, it might be urologist, nephrologist, or stone nurse, or whoever it is that leads, should bring in patients' preferences. And these are challenging decision-making processes with an MDT, and actually all the MDT members can advise, and that makes it really, useful. So just to say, Matthew, what would be your top 3 essentials to improve clinical decision-making with a stone MDT for management of the high-risk patients, stone formers?
Yeah, I think for me, we talked about this a lot today, but involving the patient, of course, and all of the decisions. And what we were successful with here was setting up a collaborative environment with pediatric and adult specialties for stone formers. And this has really facilitated nice transitions of care and referrals from the peds clinic to the adult clinic. And then just learning about the available tools in your area. So again, we talked about some genetic testing that are actually sponsored in the United States, so completely free, that have been really, really valuable and helpful for us. And best way of obtaining a 24-hour urine collection, you get mailing, or do they come to your own lab? And then if you feel like you lack the necessary resources or items at your own center, then find the nearest stone center to you so the patient can get the care that you feel they need.
It's very good advice. I agree. Tim, same question. What would your top 3 essentials be to improve clinical decision making in the stone MDT?
So I think vital, the complete clinical information to be available at the time of the MDT discussion, including the patient wishes. Ideally, that's not always going to be the case. Adequate time is important. It's important that your place of work is prepared to invest in properly funding an MDT. And I think the importance of having all the core members present for discussion. So having your stone biochemist, having your urologist, having your radiologist. I think they're the 3 things that are within the MDT.
Okay, now I think it's important to have the members and, of course, documentation, communication as a part of that as well, so that the patients can listen to it and then following the pathway. If it's a urology pathway, making sure the nephrology is plugged in and vice versa. So thank you so much to Dr. Breeggemann and Dr. Bryant for joining this discussion and sharing your insights. And once again, I'd encourage listeners to listen to the podcast, part 1 of the Stone MDT, and now the part 2 of the Stone MDT. Thanks again to Yogita and the EAU podcast team for this wonderful opportunity and to help the stone, especially the complex patients, benefit from this, and the clinicians to come to some kind of agreement or some kind of wisdom about how it should be run. Thank you once again to all of you.
Thank you for this insightful episode. We are sure our listeners enjoyed it. Medical writing support was provided by Accenture Song Life Sciences with unrestricted funding from Novo Nordisk, with no involvement in the program or speaker selection. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.